Good morning, good afternoon, good evening to everyone. We're going to start the webinar promptly because we do have a very full agenda and we want to allow time, hopefully at the end, for some questions and answer. But before opening it up officially with a welcome from Dr. Balaganatra, I will be providing a couple housekeeping rules. And first and foremost is that interpretation into French and Spanish is available, and you should see it at the bottom of your screen with the world or the globe icon. And then we will be recording this webinar, and the recordings will be made available in all the 3 languages afterwards, and we'll circulate that link when it's ready. And in addition, one more rule is just to make sure for your questions to be posted in the Q&A parts and not the chat. So that will best be seen by our panelists. So that will sum up the starts. And then I would like to pass the microphone over to Dr. Balaganatra, the head for the prevention of unsafe abortion. Thank you.
Thank you. And really, it's a great pleasure on behalf of the department, IBP, and specifically the Preventing Unsafe Abortion Unit, to welcome you to this 1 year since the guideline webinar. Can you believe it? It seems just like yesterday that many of you who I see are logged onto this webinar were discussing with us the events around the launch, and it's already 1 year. We're really, really happy and pleased at the way this guideline has been received in the past year, and we have been hearing about all of the different exciting ways in which many of you have put these guidelines and our recommendations to use. So really, today is a time when we would hear specifically from some of you, but hopefully from all of you using the chat function to tell us in different ways in which you have used the guideline in the past year and ideas for how we can ensure that what the recommendations are on paper can really get translated into reality. But before we go into those specific discussions, just to remind those who might be new on this call, a quick update on the guideline and the related resources that we actually have available. Magdies, would you be able to show the slide? So we do have the guideline available in all of the 6 UN languages. You can already see English, Russian, French, and Spanish on our websites, and Chinese and Arabic will be up any day now, so keep a lookout for those. We also, of course, already have the summaries in all of the languages available. Guideline is available both as a PDF format and in an interactive digital format, so that helps you to move between all the recommendations and look for information that you might need. But it's also not just the guideline. We all know that the recommendations are at a high level, and we really need more information in order to be able to actually translate those recommendations into practice. So we're in the process of developing a series of operational tools, but some of these are already out and available. Most importantly, we have the operational guidance on the law and policy recommendations. As you've seen, the guideline contains 7 recommendations around law and policy, and it's impossible that any country will move from where they are to a completely adopting all of these recommendations. It's bound to be an incremental process. And in order to give people a sense of how to begin from where they are and to make movement, we produce this operational guidance and brief. And again, this is still a prelude to more detailed information coming out later. There are also a number of other operational tools that will come over the course of this coming year, most importantly, a handbook on clinical practice. But already you can access this little chart, which gives a summary of the clinical recommendations in brief, and that's a useful tool for providers and health workers to have. So with that sort of description of what we have available, I think it's time to just hear from all of you how you've used all of these materials. Back to you, Karen.
Okay, thank you. And yes, I realized I did not introduce myself. Karen Kim, Medical Officer with the Prevention of Unsafe Abortion Unit, and pleasure to be here. And also just a few more products that have been out, and so that's there are. We've conducted a webinar series that will continue to carry out. And this is, there is one of the overview of recommendations. And then there was a law and policy webinar conducted in the summertime. So the recordings are available. And then we have a set of infographics for getting the message out there. And you can see that in the bottom. And we have a resource kit to get you into the nitty-gritty of the guideline, but in a very tight and efficient manner, and as well provides additional links to the various resources coming from the abortion units. And then a linked product that helps inform their guideline recommendations towards the health workers is the Family Planning and Comprehensive Abortion Care Competency Toolkit. And so it comes in 2 volumes, volume 1 and 2, and that was recently published in December. So we hope that these products will be well used over the next year. Okay, so if we can advance the next slide, I'm happy to introduce our first presenter. We have Francelle Tutley, and she is our technical specialist for SRHR and maternal and newborn health at UNFPA. And she serves as a focal point for comprehensive abortion care. She'll be providing us an overview of the global aspects of how these guidelines have been used. Thank you, Francelle.
Thank you, Karen. Hello, everyone. Good morning, good afternoon, good evening. My name is Francelle Tutley, as Karen just said, and I work at UNFPA, and it's a pleasure to be here with all of you. I'm going to discuss the ways that we as an organization have disseminated and implemented the WHO abortion care guideline since its release last year. Next slide. So I'll start with an overview of UNFPA's work on comprehensive abortion care, and then I'll go into what we see as some of the main opportunities inherent in the guideline, and then I'll talk through some of the global and regional dissemination that we've undertaken before concluding. Next slide, please. So I thought I would start by providing some context on UNFPA's work on abortion. It is grounded on the ICPD program of action and our organizational strategic plan. The focus of our work is on the prevention of unintended pregnancy, unsafe abortion, access to safe abortion care to the full extent of national laws, and post-abortion care everywhere. UNFPA's strategic plan aims to achieve 3 transformative results, including the first one, which is around ending preventable maternal mortality. The strategic plan underscores the contribution of unsafe abortion to maternal mortality and morbidity. Many of you will have seen the newly released figures that in many contexts globally, maternal mortality is increasing or stagnating. There were nearly 800 maternal deaths every single day in 2020, which equates to 1 death every 2 minutes. This is a strong reminder of the importance of focusing on this key issue. We recognize that tackling unsafe abortion and improving access to safe and quality abortion care are critical to delivering on our strategic plan. Next slide, please. Like so many allies here in the virtual room, UNFPA welcomed the WHO abortion care guideline last year and the opportunities that it affords us all to ensure women, girls, and pregnant people can exercise their sexual and reproductive health and rights and receive safe and quality abortion care. Firstly, it serves as an advocacy tool and a discussion starter to keep abortion part of the dialogue on SRHR and also maternal health, on primary healthcare and universal health coverage. The data included in the guideline and the recommendations allow for progressive discussions on laws and policies related to abortion, alignment with international human rights standards, and a strong paradigm shift from focusing solely on indications-based advocacy to broader advocacy around honoring the breadth of women's choices. The guideline provides an opening for the updating of national clinical standards and guidelines to ensure quality, comprehensive abortion care for all pregnant people. By considering the importance of the enabling environment for access to SRHR, updated clinical guidelines and service delivery models with a strong focus on self-care, the guidelines offer an opportunity to accelerate existing efforts to expand SRHR. And foundationally, the guidelines offer a reminder to always put women and the pregnant person at the center of all efforts, supporting choices, honoring individual preferences, values, and circumstances. Next slide, please. With all of that as background, I'd like to share a few examples of the ways UNFPA has worked with the guideline. At the global level, we disseminated it by sharing it alongside our organizational position on abortion, and we held a webinar that brought together staff across regions, levels, and roles to discuss the guideline. As part of that webinar, we had presentations by some of our regional offices, including East and Southern Africa and Asia Pacific, who spoke to the importance of the guideline in their context. This also provided some inspiration for other regions and for countries to engage with the guideline and see its potential. It has started conversations for us as an organization around our messaging and our framing of abortion-related issues. For example, consideration for talking about safe and quality abortion, framing the enabling environment around the 3 core areas identified in the guideline, talking about abortion as essential healthcare, and normalizing and integrating conversations on abortion in our broader work. Next slide, please. Moving into some of the ways our regions have run with the guideline. In Eastern Europe and Central Asia, UNFPA and WHO rolled out the guideline at a joint online conference in the framework of the SRH Regional Joint Program. The objective of the conference was to roll out the 4 new SRMNCH guidelines across 17 countries in ICA region. And the webinar brought together over 60 representatives from ministries of health and medical professionals, including those in charge of OBGYN and neonatal health care in participating countries, from institutes of postgraduate education, as well as leading gynecologists and neonatologists and professional societies. And this conference inspired a number of these countries to update their national guidelines accordingly. Next slide, please. In the East and Southern Africa region, in Rwanda, the National CAC guideline was successfully revised at the end of the year in partnership with the Rwanda Biomedical Center. And the process involved all the main actors in the field of maternal and child health in Rwanda through the technical working groups for maternal and child health. The current new guideline clearly defines the pathways of clients seeking the termination of pregnancy and defines the role of healthcare providers, as well as guidance on who's eligible for termination of pregnancy. Telemedicine abortion services are being tested in the country, which allows women who have a gestational age of 12 weeks or less to access abortion services closer to their homes. Copies of the guideline were printed and will be distributed and disseminated this year alongside trainings and mentorship for healthcare providers. In Ethiopia, under the leadership of the Ministry of Health, UNFPA, together with WHO and IPAS, held a workshop to sensitize MOH officials, maternal and child health staff, safe abortion technical working group members, safe motherhood technical working groups, and other partners on the guideline. As part of the workshop, the group conducted a strengths, weaknesses, opportunities, and threats analysis on the current guideline, and those findings were fed into the revision, which is still ongoing. Next slide, please. In Zambia, participants from the Ministry of Health, UNFPA, CHAI, MSI in Zambia, and other partners participated in a WHO-supported workshop to review the CAC guidelines and adapt them to global WHO standards. UNFPA participated in the adaptation process and supported the finalization, as well as the adaptation of the CAC training manual. And the training manual was piloted later during a CAC training of trainer. The updated guidelines are in their final stages of approval at the Ministry of Health. In Mozambique, in partnership, sorry, last slide, one more point. In partnership with the WHO and the Ministry of Health, the new guidelines were presented to the CAC Technical Working Group, and the Association for OBGYNs also presented on the guidelines during a national maternal health meeting. So far, there are no new recommendations or guidelines, but the CAC Technical Working Group is committed to following that up. Next slide, please. In Latin America and the Caribbean, our focus so far has been largely internal. UNFPA held discussions with our SRHR advisors across the region. Given all the momentum in the region, the team also agreed to put together a repository of information and a training portal on abortion for staff to work more proactively on the topic. The portal includes a 3-module training that covers existing laws and policies from across the region, information on the updated clinical and service delivery recommendations as part of the guideline, and an examination of existing barriers to improving access to abortion care, as well as opportunities across the region. The UNFPA LAC Regional Office also held a series of dissemination webinars on the guideline to ensure strong understanding and engagement with them across the region. Next slide, please. To conclude, I hope this has given you a flavor of the ways in which we as an organization have engaged with the guideline, the opportunities that we feel it affords us, and the value that we've really placed on it as an organization. We will continue to work across regions and countries to better align with the guideline and to support women's and girls' improved ability to exercise their SRHR and access comprehensive abortion care. This is the start of an evolving conversation, and we look forward to working with all of you as partners with a shared vision to take this forward to ensure that all people have rights and choices. Thank you.
Thank you so much, Raxel. Now that was a great start, giving us that global aspect, and now we'll be zoning in on the regional aspect of the guideline dissemination. I'm happy to introduce Dr. Rodolfo Gomez Consteleon, and he is an obstetrician gynecologist who has served since 2015 as the regional advisor for sexual and reproductive health at the Latin American Center for Perinatology, Women's and Reproductive Health with the Pan American Health Organization, WHO. You can go ahead, Dr. Gomez. Thank you.
Thank you very much, Karen and the WHO team. I will be sharing my screen to share with you some few ideas on our dissemination in the Americas of the WHO guideline, the new guideline on abortion. I would love to speak in Spanish, but having translation is fine. I was searching in the list of participants. We have very few from my region, from Latin America, and I will follow that in English just for covering the big majority. I want to share some information on the landscape of abortion in our region. Just a short video. showing that landscape information about our work, my colleague Franciel talked a minute ago about the UN, the United Nations framework on working on abortion. We, as Pan American Health Organization, we have the same framework and we follow the same rules. But we work directly with the ministries of health in countries in Latin America. We, as the video mentioned, built a network of sentinel centers in the region that work in the different context of abortion or miscarriage. Some countries, 4 of them, are banned, totally forbidden the abortion care offered in the health system legally. And other 4 are by request. We have, and in the middle, we have many others that with few indications. We have really a very unequal region with restricted and really open policies and laws. We work with the full range, and we call women in abortion situation, like means from where it's totally banned and to the country that is by request, in the full range, using the same kind of information with the same record. We build that Sentinel sites network, and we have now more than 250,000 cases in our database. Each one of the centers submit confidentially the information on the clinical care. The record is a clinical record. That is an important difference. It's not a questionnaire. It's a clinical record with all the confidentiality protected as a clinical record. We receive that information with no names, and we are monitoring, over time what happened, if the law changed, if some, new implementation, new guideline, an updated information, or analyzing the difference between countries and the political, impact on changing the law, what happened after that. The network is really active, and we use, this is an example of the record. This is the clinical record that we call SIP-A, Perinatal Information System Abortion Care, and we include near miss as one element of care. This is, in Latin America, is well known that the perinatal record for birth is used for more than 40 years. And from 2015, we start recording abortions in Sentinel sites. 13 countries, more than 30 Sentinel sites, contributing with the data. We use smartphones, Mac or Windows computers to fill the form, even could be filled in paper and then submitted by internet, and we take care of the database, as I mentioned before. This is an example of how we worked trying to strengthen the analysis of the data that our region have. We developed EVI-SIP as a strategy. SIP, in Perinatal Information System, we developed a strategy reinforcing the need of the analysis of the data, just to make sure that inequalities are reduced and access to care and quality of care are monitored over time. This is an example of one publication that is coming after this exercise, that is analyzing in 3 different legal contexts what happened with the contraception uptake following an abortion. And this is only an example. There are a long list of publications that our Sentinel sites are producing evidence on policy, national guidelines, implementation, and they became like the gold standard for high quality of care in the region. And this is our Montevideo city, a very nice city in the south where we developed that strategy. Coming this new guideline in that landscape with it, totally banned, remember that, and totally open access for abortion in the region, replacing the previous ones, the previous national guidelines. We not only help in the translation of all the information and the toolkits, and being ready beforehand, just before the launching. As Bella mentioned, a year ago, we were discussing about the best ways to launch that in the region. This is a simple, action that we did in our region. First, we were part of the development of all the previous guidelines and this new guideline, and we participated in the definition of the strategies for dissemination. That is an important issue. Then we started with the first adopters. First adopters first. That means the MUSA network were the first area, even before the official launch. We tested and we shared that with our network, and the team in WHO shared an announcement with those sentinel sites just on time for being ready for the new guideline. Then as UNFPA, we disseminated the new guideline inside of the organization, the Pan American Health Organization. We invited all the PWRs, are the PAHO representatives in countries, with the focal point for the family and community health area in the region, to get informed about the new guidelines and the difference between the old and the new guidelines. After that, we prepare an external dissemination in regional networks like PPFA, IPAS, by request. Many organizations that have coordinated actions over Latin America and the Caribbean ask for help officially to the Pan American Health Organization disseminating the WHO guidelines. And we did it. We participated in those webinars, seminars, etc. And we have a special action with the professional associations in regional conferences. FIGO and FLASOG, receive our participation in the dissemination of the guideline in regional conferences. Some countries, in the meantime, were updating the national abortion guidelines, like, for example, Mexico. Mexico start modifying the new abortion guidelines in the meantime where this guideline came out. And we were helping the country to use the appropriate resources to have a very good updated version of the national policy. And on the other hand, we have many countries improving access to self-care, and the self-abortion or the self-care in abortion were really important in many countries. And the COVID-19 pandemic came to modify abortion care in many countries. Some countries like Chile, for example, that were starting using MBA after the changes in the law, that was forbidden for any cause, and then 3 causes could be used to offer legal abortion in Chile. And after the law was changed, the small numbers came out, and the registration of the SIP-A was used, because we have 3 sentinel sites in Chile, and we saw the increase in numbers. But when the pandemic came, they moved from the MVA, that is a WHO recommended practice, to medical abortion, and they moved for more, out of the facility kind of care. And telemedicine in Colombia, when was, after the pandemic start, the restriction for movements, some of our sentinel sites implemented telemedicine very successfully and very well documented, because they have previous databases, and then the implementation of the new recommendation from WHO in time of the pandemic, and then they published the results. And we developed a post-pregnancy contraception training, and that includes post-abortion. And we have more than 30,000 people doing the training. Sorry, you can see here in blue the countries where the training is implemented. We developed for Latin America and the Caribbean, but many countries outside of our region are doing it because the training is in Spanish, Portuguese, English, and French. And this is, post-pregnancy contraception that includes the new elements of the guideline. And this is how we, promote the trainings. People can do it in our platform, in the PAHO platform that, is free of charge. And we are pushing the countries to have the primary level of care trained in immediate post-abortion and postpartum contraception. And this is part of the team that participated. You will see here many faces from WHO, Antonella and Caron. They were part of the ABC in person, and we were very happy to have them increasing and strengthening the analysis capacity for abortion care in our region. Thank you so much. And I have here for questions.
Thank you so much, Rodolfo. It's fantastic to see that picture so warm. Good memories. So before I introduce our third and final speaker, just a reminder again to please put your questions into the Q&A function, into the box. And then also, as Bella had highlighted, you can use the chat function to tell us about your experiences or the products that you have been doing, because this is, there's been many of you that have been working hard, and if there was only more time for everyone to share, but it would be great to hear from you, even through the chat, and we welcome that. But questions in the Q&A and then personal sharing on the chats would be fantastic. Okay, so now we've heard from the region and we're going to go to the country. And I have the pleasure to introduce Dr. Marura, and he is a public health and sexual and reproductive health specialist with over 20 years of experience in the field. And he is also an SRH champion with the RCOG Making Abortion Safe program. This program works in collaboration with healthcare professionals like Dr. Marura, not only in Zimbabwe, but also in Nigeria, Rwanda, Sierra Leone, and Sudan. And their aim is to improve women's and girls' access to quality abortion care. So take it away, Dr. Marura.
Thank you very much for giving me this opportunity to be able to share with you the experience as working as a sexual reproductive health champion within Zimbabwe, and also working with RCOG. I would also want to thank WHO for organizing this particular webinar on the 1-year anniversary of the abortion care guidelines. The outline of my presentation is I'll take you through an introduction, then look at the access to abortion services within Zimbabwe, the methods of abortion currently in use. Then I'll also discuss the rationale for the new guidelines, which are going to be developed soon, and the methodology that will be used in developing these new guidelines. And then I'll also discuss on the envisioned impact of the new guidelines, and then conclude the presentation. So unsafe abortion is recognized as a significant contributor to both mortality and morbidity among women of reproductive age group. In Zimbabwe, 1 in 10 pregnancies end in abortion, and this is usually clandestine and potentially unsafe. 4 in 10 women who have an abortion need treatment for complications, which are mainly bleeding and sepsis. Due to the COVID-19 pandemic, we have seen a rise in sexual gender-based violence, and also limited access to sexual reproductive health services, and this has resulted in increased unwanted pregnancies. The Termination of Pregnancy Act of 1977, which is currently used for providing abortion services in Zimbabwe, is outdated, as you can see. And termination of pregnancy is allowed mainly for three particular, reasons, which is when the woman's life is in danger, in the case of incest or rape, and where there's fetal impairment. So termination can only be performed at public health facilities after a legal authorization in Zimbabwe. Access to legal abortion is therefore difficult, and women are faced with a myriad of challenges. Legal and administrative barriers coupled with stigma amongst both women and health service providers, and fear of legal and social repercussions, as well as risking imprisonment, are deterrent factors for safe abortion in the country. Next slide. In terms of access to abortion services, over the years, some medical personnel have taken advantage of the many women desperate to get rid of unwanted pregnancy by charging exorbitant fees, up to $450 for these procedures. Traditional herbalists also come in and they charge fees that range from $25 to $65 for an abortion. These exorbitant charges have forced many young girls and women who cannot afford such fees to seek alternative ways to abort the pregnancies. Things like herbs, laxatives, toxic products, as well as coat hanger wire or knitting needles are often used to end unwanted pregnancies in Zimbabwe. Most of these women eventually present to health facilities with complications, seeking post-abortion care services, which are highly costly to the health system. Next slide. Zimbabwe has made efforts to reduce maternal mortality through improving post-abortion care services. This includes launching the training program for MVA, manual vacuum aspiration, in 2008, inclusion of misoprostol in the essential drug list in 2011, piloting training on using misoprostol for post-abortion care in 2013, and updating national guidelines for abortion care in 2014 to expand free access to post-abortion care services at primary care level. Majority of post-abortion care services, 85%, is provided at public health facilities, with about 25,000 patients treated annually in 2016, with abortion being one of the top 10 causes of admissions in the country, with over 10,000 patients admitted due to complications of abortion each year. Women seeking post-abortion care reported experiencing substantial delays between being seen at a health facility and receiving complete treatment due to lack of money, waiting delays at health facilities, or shortage of staffing or medicines, and inability to complete treatment at a single facility. A 2016 study showed that only 20% of facilities had basic capability to provide post-abortion care services. 5% of public health facilities assessed faced stockout challenges of misoprostol, and 49% had stockouts of MVA kits. It is essential that women are offered contraception after abortion, but this requires strengthening, especially on provision of wider method mix for family planning. Next slide. In terms of the current abortion methods being used in the country, we have manual vacuum aspiration, dilatation and curettage, and misoprostol, depending on the gestation. The most common procedure used is DNC. 61% of the patients are treated with this method. Then medical abortion, 18%, and MVA, 13%. DNC is the most commonly used method for post-abortion care in public hospitals due to the low costs associated with the method. Instruments for provision of PAC services are available in institutions providing service and are reusable after sterilization. Hands-on training is mainly provided for DNC and MVA provision during internship, midwifery, and on-job training. Several misoprostol products and a few mifepristone brands are registered in Zimbabwe. Efforts are currently underway to register a miso-mife combination, the combi pack. Misoprostol is a prescription drug, but has however found its way into the informal and black market. After using the misoprostol elsewhere, some of the clients later present for post-abortion care at public health facilities for further management. Next slide. I'll just look at the rationale for the new guidelines. I think the Ministry of Health and Child Care abortion care guidelines were last reviewed in 2007. They were then updated in 2014 and thus are outdated. These guidelines were not fully disseminated to all providers and stakeholders. So since the launch of the WHO guidelines in March 22, this presented Zimbabwe with an ideal opportunity to update the national guidelines and align them with the latest and current best practices in abortion care. The new comprehensive abortion care guidelines will offer strategic opportunity to improve access to comprehensive abortion services and also promote medical abortion options in Zimbabwe. Next slide. The methodology of developing these new guidelines, I think, included this was a multi-sectoral approach, and the Ministry of Health and Child Care was supported by WHO to recruit an international consultant to spearhead the process. The Ministry of Health constituted a national technical working group and an obstetrician and gynecologist expert panel to provide technical and specialist guidance to the consultant during the process. The obstetrician and gynecologist expert panel and the technical working group reviewed the initial draft document and submitted recommendations to the ministry and the consultant. The technical working group then held consultative meetings with all key stakeholders to review the draft guidelines, and then had interactive discussions with the consultants throughout the process. The final draft was submitted to the Ministry of Health and Child Care in December 2022, together with the training manual for approval. Guideline dissemination will involve orientation of providers at all levels and include both in-service and pre-service training. The country will also utilize existing forum for continuous professional development through the relevant professional associations. Next slide. In terms of the impact which is envisioned due to the new guidelines, I think the new guidelines can significantly improve access to comprehensive abortion care, including medical abortion in Zimbabwe. Better dissemination and orientation on the new guidelines will empower health providers and capacitate them to provide quality services. The guidelines will also ensure registration and availability of essential commodities, e.g. the combi pack required for the ideal minimum standard of care package. Through the new abortion guidelines, professional associations will be urged to review the training curricula for all healthcare providers. This will also be an opportunity to advocate with policymakers and professional bodies for review of the Termination of Pregnancy Act and also streamline the Termination of Pregnancy administrative procedures. Public and private sector health system will be capacitated by the new guidelines to provide services in line with WHO best practice. Next slide. In terms of our conclusion, the abortion guidelines development process provide an opportunity to strengthen advocacy efforts towards removing legal and administrative barriers in providing abortion care, thereby improving access to quality services. Review of the guidelines will align service and treatment protocols with current best practices, thereby empowering service providers to offer services confidently in a conducive environment. Health provider curricular revision in line with the new guidelines will be a cost-effective strategy for capacitated providers in comprehensive abortion care. Providers in both public and private sector will utilize the guidelines to improve access to comprehensive and quality abortion services. I would like to acknowledge the Ministry of Health and Child Care, World Health Organization, Making Abortion Safe program, our development partners, implementing partners, and civil society organizations that contributed to the putting together of this presentation. So that is my last slide. Thank you very much.
Thank you so much, Dr. Mura. And this is perfect because we have a little time for questions, and I just received a question directly to you, but of course we can open it up to our other panelists. And we have an attendee that's asking what actions by religious leaders have occurred, if any, in the adoption of the guidelines, particularly in Zimbabwe, but also this can be opened up to the other panelists. So Dr. Mura, are you able to take the first question, please?
Thank you very much for that question. Yes, I think it's quite important issue regarding the religious leaders within the country in relation to the guidelines. But firstly, I would like to say that the guidelines are primarily for program managers and policymakers, and also for service providers within the country. And as I have alluded in my presentation, I think the guidelines will also be used as an advocacy to push for the changes in terms of the policy and also legal and other issues that are, contentious with regard to the Termination of Pregnancy Act. But primarily the guidelines will be used by program managers and service providers to ensure that they provide comprehensive quality abortion care services. But we'll also take up advocacy with policymakers, including religious leaders and traditional leaders, in terms of information and empowering communities in able to be aware about the issues around unsafe abortion.
Thank you, Dr. And now seeing some more questions coming in. So I'll also direct this now to either or both Rodolfo and myself. And then I think we'll have time for Dr. Mura to come in on this question because I'm just keeping an eye on the time. But this is a question actually that's has popped up, but also something that I've been wondering too, is what are the hopes for the next year and for in terms of the implementation of the guideline recommendations. We've been speaking about dissemination efforts over the past year, and it's true that right now we are transitioning to making sure that now they're taken up. And so would love to hear from all three of our speakers on their thoughts and inputs on the steps that are needed to move forward and any major gaps that have been identified. So let me start with Francel.
Sure. Thank you, Karen. Thank you for the question. So the majority of our focus really has been on integrating abortion into ongoing discussions with technical working groups, for example, on related topics, so safe motherhood, and of course, safe abortion as well. So I think that work is critical and needs to continue. For us, it's really about finding those entry points, those strategic entry points to integrate conversations on abortion and to bring the guidelines and to use the guidelines as evidence for those conversations and to advance those conversations across the different areas of the abortion ecosystem that are identified in the guideline. Across many of the country offices, as I discussed earlier, we're really supporting the updating of clinical standards and guidelines for abortion. So coming up, I think the work is really around capacitation, training, disseminating those guidelines and making sure that healthcare providers and others are really aware and able to, engage with and understand the content within and the importance of quality care as per the updated guideline. So along with that, UNFPA obviously has an important role to play in ensuring that commodities are available. So we are, as part of our supplies partnership work, we are working across numerous countries to make sure that CAC commodities are available so that work can really be implemented. Also, I think obviously there's a lot of work around community engagement and ensuring that once services are available, healthcare providers are trained, guidelines are disseminated and understood, that women and girls and pregnant people can actually access those services. So that's certainly something that we'll be looking into moving forward. And I think also having more conversations like this and really strengthening our partnerships so that we are well aware of what others are doing and how we can collectively advance these guidelines to ensure that they are not just sitting on a shelf somewhere, but are really fully implemented and able to have an impact on people's access to care. Thanks.
And Rodolfo, I have you come in and also speak about their vision or thoughts of the next year moving forward with the guideline implementation.
Could you please speak up? It's
Yes.
very
Yes, we're just hoping to get your thoughts on the next years of moving forward with the guideline and its implementation.
Yes, thank you. Yeah, for the next year, we are planning to go deeper in the discussion with the countries that are reviewing the abortion guidelines. Are very few, particularly in areas like telemedicine, medical abortion, ambulatory care, primary level of care, and some very good experiences were done in countries like Chile or Argentina that recently changed the law and they implemented. And the telemedicine in Colombia is a very good example. Our idea is if we have resources to help that, maybe doing a south-to-south collaboration, sharing with those positive deviance countries with the other countries that are not allowing or are not advancing as expected. The positive contamination is very good. The cross positive contamination. Countries that are moving farther and faster really make the case for others that are having more difficulties. And Uruguay is a very good positive deviance example. Our idea is maybe to connect the dots, not only in the network, but also including ministries of health officials. But as you know, it's not an easy topic to discuss in many, political environments, and with elections in many countries. This is not a sexy topic to openly discuss during elections. But considering that, we will find in the next couple of years that will be our plan to help implementation at the local country level, not more regional, will be one by one at the country level where the difference can be made, and this is our initial plan and idea. We want to reinforce and to strengthen the network, because we know that the network, the club network, is the way that we showed gold standards, in the same country, having one sentinel site, having high level of quality, that is a positive contamination too. We show internally in the country with the same reality that a different quality of care can be offered. And this is another, kind of cross positive contamination strategies that we are thinking. And that is, it depends on the political will that the country have. We are trying to show, as Franciel mentioned, that is a priority, and having some donors interested in, gender, human rights, gender equality, universal access to reproductive health care for all, that will be our venue to show countries that is possible.
Thank you, Rodolfo. Fantastic. And in the remaining couple of minutes, I'll have it passed on to Dr. Marrera to just conclude with your thoughts on the next year's phase of implementing the guidelines and any additional thoughts that come to mind.
Okay. Thank you very much. I think what will be key, in our settings, is we've learned from from our past mistakes in terms of updating and developing guidelines that are not fully implemented and fully disseminated. Is one of the biggest challenges from the previous guidelines. So I think our efforts in the coming year are to ensure that the new guidelines are widely disseminated and are fully implemented, and also ensure that we use all the available platforms to ensure that we have effective dissemination of the guidelines for use, and capacitating service providers so that they are confident and they provide services without fear of victimization and without fear of stigma associated with providing these services. So I think it's one of the key issues that we need to deal with the new guidelines. The second issue is focusing on issues around areas of advocacy. Advocacy still remains key within a conservative society like ours, or most of our African countries. We need to improve and ensure that there is a lot of advocacy with policymakers, traditional leaders, religious leaders, and policymakers, so that we create a conducive environment for improving access to safe abortion services within the country. I think those would be the key issues to focus on in the current coming year for the new guidelines. Thank you.
Thank you so much. And if I can ask the slides to be put back up as we close our webinar, I'd like to thank our wonderful panelists for sharing their experiences. And I'd like to thank the participants in sharing their experiences that has come through. I'm sorry that there wasn't enough time to go through these great questions, but as was said, it's really we continue going out there and talking and learning from the past, and continue to disseminate and discuss and lean heavily upon our partners and those on the ground through training and through professional associations to work together and continue talking about this. And then if I could just direct your attention to the screen that shows the guideline that's available in various formats, and this is the one on the right is the usual PDF documents that's available for download. And then on the left, there is an interactive web-based format, and it can be seen located at this website below. So please, I encourage you to visit it at srhr.org/abortion fair. This is what Bella had brought up in the beginning of her welcome, where this allows the interactive, you can be part of the interactivity of the recommendations that all link.
You can. Oh, sorry, Karen, you're back. You disappeared for a while.
Okay, sorry, I'm back now. Okay, apologies. So I am just ending with this slide to please explore the interactive web-based formats seen here at this website address on the left. You can see and view the interaction of the recommendations. And we've actually added a new component where there's the quick links on the home page. And the first one will show you what's new, what's updated, and what's been unchanged in the list of 54 recommendations. So thank you so much, and we hope to see you again. Good day.